Hello and welcome to Addressing Racial Disparities in Healthcare. Thanks to all of our participants who are joining us today from all around the world. This webinar is brought to you by Harvard Online and the Disparities Solutions Center at Massachusetts General Hospital. Before we get started, I'll run through some basic information on our webinar. So all participants will stay muted and the chat function will be turned off for the duration of the event. We do want to hear from you though. So questions can be submitted using the Q&A button that you'll see at the top of your Zoom screen, or you can submit questions through the comments section if you're joining us via live stream. For the last 15 minutes of the webinar, the participants will answer your questions. So we encourage you to share. You can also upvote questions that resonate with you. This event is being presented in conjunction with the launch of our latest course, Reducing Racial Disparities in Healthcare, which begins on Wednesday, March 8th, 2023. Applications are due February 27th. When the webinar is over, we'll be sending a discount code to all participants in the chat, as well as an email that will go out following the webinar. We're excited to introduce you to our moderator and panelists for today's event. Our moderator is Aswita Tan-McGrory, one of the faculty who teaches our upcoming course, Reducing Racial Disparities in Healthcare. She is also the director of the Disparities Solutions Center and director of Equity and Care Implementation at Massachusetts General Hospital. Hello, Aswita. Thank you for joining us. And now I'll let you introduce the rest of our panelists.
Thank you, Jim. I want to welcome everybody and thank them for joining us today. And I have three colleagues and also friends with me today. I have Dr. Lenny Lopez, Andrea Madu, and Dr. Esteban Barreto. And so I'm going to kick off this webinar. We're going to have a lively discussion. And as was previously mentioned, if you have questions, please submit them through the Q&A function. And we will use the last 15 minutes to go through those. But first, I want to ask each of the panelists to go ahead and introduce themselves and then really kind of let us know, like, what is sort of the driving force for you in doing this work around addressing racial and ethnic disparities and working on equity. And Lenny, I'll start with you, and then Andrea, I'll have you go second.
Well, thank you, Aswita. It's wonderful to be here and on this panel on this very important topic. My name is Lenny Lopez, and I am a professor of medicine and the chief of hospital medicine at the University of California, San Francisco, and the VA Medical Center here. And I'm also a healthcare disparities researcher and implementation science researcher. I think for me, disparities work and elimination of disparities and really bringing equity into healthcare comes from my family experiences and also my patient care. Every day, I see individuals that are challenged by access barriers, challenges around language barriers, lack of access to high quality care, and most importantly, from the moment that they enter the healthcare system, from registration all the way to their outcomes, equity has to be the number one true north. So that's really my passion and energy comes from that.
Thank you, Lenny. Andrea?
Hi, everyone. My name is Andrea Madu. So happy to be here and excited to have a conversation on this topic. I am currently a consultant at the Bridgespan group, and I work largely with nonprofits and philanthropists to accelerate their impact and solve really tough challenges centered around equity. But I started my career in healthcare, working to address disparities for youth regarding HIV/AIDS, and then working at the DSC with the panelists on this call. I'm really interested in this work because I've seen for myself the differential treatment that people receive based on language proficiency. My family emigrated from Nigeria in the 80s, and I remember going to the hospital as a child and seeing how doctors treated my grandmother, who could not speak English, very different from me and my siblings. And also my mom, who speaks English fluently but has a strong accent, would have to use her knowledge as a nurse to really navigate the healthcare system and for her to get respect and be treated with the respect that she deserved. So those experiences have always fueled me to work on reducing health disparities in healthcare. And I've seen how this poor treatment can translate to poor outcomes for patients. And then personally for myself, I know there's a very high maternal mortality rate for Black women, regardless of class. And I've always been terrified of the prospect of giving birth because I know what the outcomes are for people who look like me. And so I'm always terrified for my family members, even though they're in the medical profession. So in a way, it affects me, it affects the people in my family. And that realization has made me want to advocate for people who may not have the privilege and knowledge to navigate through that healthcare system.
Thank you, Andrea. Esteban.
Thank you, Aswita. Great to be here. Thank you so much for the invitation. Similarly to Lenny and Andrea, a lot of my passion for this work comes from lived experience. As an immigrant to the US myself, I also had to navigate different systems with my family, especially the medical system, and having family members go through different language barriers really allowed me to focus on this type of work. I would also say from early in college, I started working as a research assistant and worked in a variety of different research and quality improvement projects. And that gave me a great exposure into inclusive data collection techniques, also different sampling techniques that we could use that allowed us to hear from those patients who may otherwise be excluded from routine assessments. So I will say it's a combination of both lived experience and also early professional experience where it really allowed me to explore barriers in a more tailored way and hear from those voices who may, as I said, may otherwise be excluded from different assessments. Once again, great to be here and on this important conversation.
Thank you. I think the overwhelming theme I'm hearing is this is personal to us, right? Very personal. I mean, not only are we motivated because, as many people say, it's the right thing to do, but also it resonates with many of us. It's the people that we love, that we see as patients. It's the experiences we had in our past childhood. So I think there's a lot here when we do this work. And I think it's also a way that we have to sort of protect ourselves. I'll just put that out there. This is tough work. And having a community of like-minded colleagues and friends like you guys goes a long way into, creating that sort of safe space. A lot has changed in this field since the pandemic. And I kind of want to talk about that because we were doing this work before the pandemic, really launched the center with the IOM report on equal treatment. And so we have seen sort of this arc of how this has changed. And I would say the last 3 years in particular has been sort of amazing, but also challenging. So I would love to hear from you, from your perspective, how has the field changed and how we do this work? And I'll start with Andrea and then Esteban, have you go second.
Sure. So I'll caveat that I was working in philanthropy during this time, but I was working with a lot of organizations that are addressing the social determinants of health and are kind of working in tandem with hospitals. And I remember before the pandemic, it was always an uphill battle to try and convince people why this work was important. We had the data, but the data hadn't come into sharp focus yet. Once the pandemic hit, and it was very clear that one, leaders of color were on the front lines and were also having a higher rate of COVID. And then the service providers as well were from the same background. All of a sudden, everyone was investing in these organizations led by people of color who've been doing this work since the beginning. We're taking on an extra burden. And so it really did bring into sharp focus the idea that this pandemic is something everyone's dealing with, but it's actually affecting these specific populations. So that was, to me, exciting to see because finally the work that we had been doing was very evident. But then kind of a few years later and coming back to that work, because the pandemic has been declared over, even though people are still dealing with this, I fear that there's kind of a retracting now where like that knowledge is kind of going backwards and less of a focus is on it. So I think, in my opinion, I think we've moved forward, but then there's kind of a pendulum swing back where I think more of that work needs to continue to be done so that people are still educated in why this is important.
Yeah, I think the burnout rate is high on a topic like this, can be. Esteban, what do you think?
Yeah, and I agree with the points that Andrea brought, and also you, Aswita, said that a lot has changed since the pandemic. I remember right before the pandemic, I was still working on my doctoral dissertation, which focused on the effects of diversity work culture on different organizational outcomes. And I remember when I was trying to argue for the need of having a diverse work culture, it wasn't as clear. I felt, there were a lot of pieces that I was trying to really argue for. But then during the pandemic, as there was an increased sense of urgency. I feel like if I would have written that dissertation during the pandemic or after the pandemic, I wouldn't have to explain myself so much in terms of the importance of having a diverse workforce, particularly in healthcare settings where we serve diverse patient populations. So I think it increased a sense of urgency. A lot of people wanted to know about it. Leaders focusing not only their efforts, their resources, but bring their values, professional but yet there's a lot of work that has to be done. I also agree with Andrea that there may be some backtracking at the moment. Not sure what that really is about, but especially during the first waves of the pandemic, we did see a lot of energy in trying to tackle these barriers.
You raise an interesting point, and Lenny, you and I have talked about this idea that I think everybody can now get on board the importance of diversifying our workforce, our team, our providers. And that seems a comfortable space to a certain extent for people to talk about, particularly in healthcare. But this idea of and it has to be paired with equitable care or making sure that there's no racial and ethnic disparities has sort of gotten less traction. Lenny, can you talk a little bit about that sort of from your perspective of overseeing, hospital medicine in a clinical setting and being the chief, the challenges of that?
Yeah, I'm reflecting on what you're saying, and also what Andrea and Esteban were sharing. Over 20 years ago, the Institute of Medicine, now known as the National Academies of Medicine, Science, and Engineering, put out a report on equal treatment. And 20 years ago, the field was just beginning the notion of collecting data around race, ethnicity, and language. And at that point, we had to justify that. And we had to create, reams of research and papers and all of these things and policy white papers in order to say this was an important issue. And I think the acceleration that's happened in the last few years has shifted not only the public discourse, but also the shift to structural changes that are needed within institutions and between institutions at both the government level all the way down through the healthcare system. So the focus has become less on individuals and more on how the structures that we have created as a healthcare system perpetuate inequities, and how can we change those things. And so there is a level of comfort that wasn't there, even 5 years ago around, well, how do we actually bring about the equity that we all feel is so important and has been front and center since the latest just social justice movements of George Floyd and others who have suffered so much. So I think the discussion really, really has shifted in that direction. So bringing that equity back into the forefront, into the center of the discussion, that's really where we're going. And so data collection is very important for monitoring and assuring quality, but at the same time, we need structural changes that will allow for true change over time to occur. So I think that's really different and very exciting about the work that we have in front of us moving forward.
Yeah, and it's interesting because I think there's a lot more buy-in, but at the same time, people are very overwhelmed with what it would take. This idea of structural racism, I feel, is fairly new to many folks. And I wonder, Lenny, or even Andrea and Esteban, if you feel that sometimes this idea that it's structural racism plays a role, and it plays a very big role. And I don't know that we as a country have really acknowledged historically how things have been designed. But do you think that gives certain people sort of like the feeling of a pass, like, oh, it's not me, it's, these things that I can't change or control?
Well, I would add that very briefly, I'll let Andrea respond as well, is that there is an element of that. And there's also that sense of being overwhelmed and realizing how deep and large the problem is. And that it's not a problem that just started yesterday, but it's been several hundred years that have allowed us to get to where we are. So when people throw their hands up in the air, it could be the past. And that's probably the element we all want to feel that we're not, causing injury to others, but it's also the sense of where do I begin and how does this start and what happened here? So I think it's all of that mixed together, but I want to give Andrea an opportunity to share her thoughts as well.
I agree, Lenny, that there's a sense of overwhelm. I think people really resonate with interpersonal racism, like my additional actions. What can I do and what have I done that's caused harm? But when you kind of zoom out to the systemic lens and noticing that it's everywhere, it's like you're a fish in water and it's all over you. I think it is overwhelming for people. But on the other side, I found that I've seen that like aha moment that happens with people when they start to realize, oh, this is like historic disinvestment and this has happened over years and it's all layered. And I think for some people who want to do that work, that education is so important. I think people can't use overwhelm as a reason not to do the work. I've seen the overwhelm happen, but I've also seen that transform into what can I do and how can we break down some of the barriers institutionally. And I think the course especially like works through that and talks through the history of racism in the US and it kind of lays it in a way that you really can't deny what's going on and just talks more about tangible ways to address that.
Yeah, I feel like that was a key piece for us to include in our course, was that we have to acknowledge how we got here, right? And it is not something that is easy to talk about, but I think Dr. Powell does a wonderful job of sort of walking us through, and it can be very eye-opening. A lot of it is stuff that we did not learn in school. And I think a lot of people were surprised by some of the things he shared. So I think that's like a key element that we have sort of built into the course that we need to start opening up. Esteban.
Yeah, I certainly agree with Lenny and Andrea in terms of the overwhelming aspect and also with Andrea's point about how it shouldn't be an excuse. Education is where, we should really focus. Fortunately, we live in some of us live in Massachusetts where we're still allowed to teach things like critical race theory. In terms of racism, I know there's a lot of different definitions and people may have different nuances. I think of racism as a system of oppression. And then, from that, there's a lot of different types of racism and racial discrimination and all that. And I think that is a good point, a good starting point, the education of these concepts and how this phenomena affects different populations. But again, I also agree with the earlier point from Lenny about the structural challenges, and we can do a whole lot in terms of data collection and trying to learn from different perspectives. But then if the structures and unfortunately the politics get in the way, it just makes our job much, much harder.
It's a good point you make about sort of, people sometimes ask me like, well, how do you know that equity has been achieved? And I would say, equity is not the end goal because it is really a journey and it consistently has to be monitored. It has to be deliberate. We are always learning something new in this field. I feel it's constantly changing. Terminology changes. Funding changes, right? People's willingness to talk about it. We've definitely seen a huge change. I mean, I think a couple of years ago, just mentioning the word racism in a boardroom, like everybody's shoulders would be like this, And so now we're saying it. Yeah, remember you try to do whatever you can to bring the message along. So you're like, okay, let me just soften it, And I'm happy to see that we can say the word racism without stuttering in boardrooms. I mean, I feel like that's progress. And so this is really a journey. I'm curious to hear from you three. What do you think we really need in the field? Like, what is the gap? Like, there's a lot here, interpersonal racism, structural racism. If we think about like healthcare organizations and healthcare in general, like what is needed from your perspective?
One thing I wanted to add to answer your question, to add to the conversation, is that what is needed is not only, I love this frame of journey, also just continued growth as part of that journey. You know, I'm happy to share that even after 20 years working in the field of equity and healthcare disparities, I'm constantly learning, and I'm constantly being pushed, and I'm constantly needing to reflect on my own implicit biases and my own starting point and my own sort of ability to communicate these things in the right settings with the different groups of people. And I think those are things that, of course, like this can really give you that space, no matter what your level of experience or background or education around these topics. It is really, as you're saying, it's really a personal journey. So I think one of the things that when this course comes live, and I'll encourage other folks to take it, is really to realize that you don't know everything, and there's so much space where you can actually continue to grow as an individual and make those changes in your own place in the universe where you are at work and in your communities.
Yeah, and I will say, like, you know, we had long discussions about content when we started designing this course, and there's probably stuff that we weren't able to include because honestly, to include everything, right? Your course would be a full year, and then you would still probably leave things out. So I think we really tried to focus on what we know best from all the organizations that we've worked with. What were sort of the core competencies that we would want you to know? What would be some of the building blocks that you as a person, you know, having to sort of think about transforming your organization, to think about racial and ethnic disparities, to think about, you know, equity, like what are some of the key components, and really bringing in the folks that we've worked with. So I totally agree that with your point, Lenny. Andrea and Esteban.
Yeah, I agree too, Lenny. That humility is so important. And I think humility was something I felt throughout this course, the idea that equity is not something that we're going to solve in our lifetimes, but there are pieces of it that we can move along a journey while we're working on it. And so I think that was very, very helpful to see. I think also just in general, structurally, I think what's needed is a pipeline of doctors who also looks like the communities that they're serving and have that lived experience to understand the cultural context of, you know, what patients are saying. That's one. And then I also think this understanding of the medical mistrust that has happened over decades or centuries, and understanding, you know, why some people might not want to come to the doctor, or why people might not be adhering to treatments. There are reasons behind that. And I think really coming to it with both humility and empathy to patients, I think is so important. And that kind of goes into the frame of understanding the history behind everything.
Yes, and I definitely agree with what it was said. Definitely a journey. We have to exercise humility. Andrea, your comment had me thinking about how we move from cultural competence to cultural humility, right? So maybe we have to think about equity, humility, and it is not easy to address healthcare disparities when there are also disparities in education, disparities in the legal system, and everything, kind of has an effect on each other, right? So in order to increase representation among health professionals, you also have to address disparities in equal opportunity to education, what children and young adults are being exposed to in terms of future career. So I think as a society, there's a lot that we still need to work on. We're talking more in particular about healthcare disparities, but I just wanted to make that point that it's, disparities are really everywhere in every single system. So we also have to think about tackling it in other fabrics of our society. One thing about this course is that, considering how complex this issue is, the speakers do explain the topics in a very comprehensive manner, and providing examples, providing different case scenarios that I was really happy with, and I found it very easy to follow along. And I also have to admit that I did learn a lot of things despite having a few years working on this field.
Yeah, Andrea and Esteban were the early adopters of the course. They actually went through the course, and I just want to thank you, first of all, for taking the time to do that. But it's very meaningful to me that somebody like you gave it a seal of approval, and that you still learn something new. I think that's an important theme that, Lenny and all of you have brought up, is that, when people talk about subject matter experts, I say, oh, that's with a caveat, because to be honest, I'm constantly learning new things. I'm constantly, in this work, you have to self-reflect. That's really the only area where you can make some concrete changes, but you have to reflect on your own journey, your own reaction to some of what you work on every day. And then also, like, it just changes. It changes constantly. It depends who's, in leadership positions, whether it's in this country or in your institution. It depends on like where the money's going. So there's a lot of sort of factors. And so I agree, like, I feel like if you're not learning anything new, then maybe, I don't know that you're ready, because I feel like we're constantly like learning. We are sort of early adopters. Probably because we've been doing this work so long, and I'm just kind of curious, like, from your perspective, in just sort of giving some like, on hindsight, I wish I had known this when doing this work. Like, what are some things that you would share with the audience from whatever role you feel is most comfortable, whether it's like a physician leadership role, where it's Esteban as sort of, evaluation component, or Andrea as like a consultant with like a really heavy vested interest in this topic, or from a personal perspective.
So I can talk about the evaluation work. One thing that I wish I knew before is that, we love timelines and deadlines and all of that. In an ideal world, we are able to meet all the deadlines for all of our projects. But then the projects that have more of an equity lens, of a health disparities lens, I feel like you need to be a little bit more flexible and sometimes pivot, right? So when you may plan the perfect goal, the perfect objective, you may come up with the perfect approach to data collection, and then you may learn that there's things that you may need to change, right? And so I wish that was one component that I learned early on. But now that is something that I do stress when I do meet with different investigators who are interested in having an equity lens to their research portfolio. And we talk about that flexibility or that ability to pivot when needed.
I think one thing I wish I had known is, one, like, how to identify people who their minds are just never going to be changed no matter what you do. But I wish I had learned those strategies to kind of transform the hearts and minds around those people, because really that's how it works, to get those allies on your side. I think there's one piece of the course that talks about the Cotter model. And I think I've always thought of creating a sense of urgency was the most important piece, but there's all of these pieces of creating the coalition, but then also trying to use that coalition to get other people involved and invested. And that's really what pushes these initiatives to be successful, more so than just saying, this is why this is important. So I wish I had known that before. I think now it's really important in the work that I do now, and especially in this healthcare work, where you are going to have to change hearts and minds. And how do you do that when you might not be the right messenger for the message, but you could find that person to help you along the way?
Yeah, it was very helpful. The Cotter model isn't designed for equity, but when I read his book, I was like, oh my God, like, this is it. This is the template of like why it's so hard to change an organization, right? Like, really all the way through. And it's when you talk about organizational transformation, he's identified what makes it successful. So I think that's a very helpful grounding in sort of this work, when you kind of feel like, oh, I don't know, like, why is it that I've been doing this work for 5 years, but it feels like I've got no traction? Then I think that model is, like, from a business perspective, very helpful. Lenny?
Yeah, reflecting on what everyone is sharing, one of the things that I've learned over time in working with organizations, working within my own organization, to address the systemic barriers, is that all the sources of disparities and the solutions for eliminating those disparities are all hyper-local, and that you can learn The goal is to learn tools and strategies, for example, the Cotter model we're talking about, to really then take it home and take it to your institution, to your organization, to your community, your place in the universe. And that's where the change happens. And so, although we have oftentimes grandiose ideas about how the world is going to change and all of these things, oftentimes it's much smaller victories that add up over time. And so those are the things where we're, Aswita, to use your metaphor of the journey, those are the things that give you strength and courage and the energy to keep doing the work. And so reframing and organizing your thinking in that way, such as what's available in this course, is an incredibly helpful process to go through.
My last question to all three of you is, this is hard work. I do feel like once you see things, you can't unsee them, and then you see them everywhere. Like if you go on vacation, in the grocery store. And so my question to you is, how do you do self-care in this work? Like, I love that all four of us have the lived experience. It allows me not to have to do the preamble of like why this is important, right? I can just skip that and go straight to like, how can we do things? But I really would love to hear from you. What is the self-care strategy you use? And mine, for example, is I don't read outside of this job any heavy books on racism, social justice. I don't watch movies about it. I've had enough. Like, I watch really bad trash TV and read detective novels. But I just know I need to refill my tank. So I would love to hear from the three of you, your strategy for doing that, because I think that's an important piece of all of this work, is the self-care. So I'll start with Esteban and then Andrea, and then I'll close it out with Lenny.
Yeah, for me, some strategies for self-care is family and friends, having open discussions about different issues. I do have to admit that I try my best to stay current to the news and everything that is going on. And I learned how to not, take things personally over the years. Also, another big part for me is working with students. I'm an instructor at the School of Social Work at Simmons, and I teach a class there each semester. And working with different students really allowed me to also stay current in different topics. For example, social issues, the different nuances, the different ways that issues are being looked at. And so those are some of the things that do help me to stay current, but also trying to practice some self-care.
Yeah, there's nothing like working with young students to get out, sort of the old archaic way of thinking. And it's sort of refreshing. Andrea?
Yeah, I feel like I plug in a lot because of my work. I really have to stay current as well. I have a group chat with my family where I'm just like, anytime something crazy happens, I'm just like, can you believe this? And we just kind of dish on it. And it makes me feel like, I'm not alone. I also like schedule 30 minutes before I have a big meeting with someone that I know is going to be like a struggle to go on a walk, or I like listen to some of my favorite music just to get me kind of hyped up to deal with that. But yeah, just creating space for joy. I think it's so important to find joy wherever you can in this work, because I know it's tough, but those moments do exist. And I really enjoy working with people who are just as passionate about it.
Yeah, that's a good point about the chat. I think we all have folks that we text to where it's like, oh my God, this person just said this. Can you believe it? And then they'll ping back and like, I can, and I'm really sorry. And that's really all sometimes you need. Lenny?
Yeah, similarly to all of the panelists, I'm just thrilled that we're even having the conversation about self-care in this space, because I think even 10 years ago, we weren't talking about self-care. And for those of us doing equity work and justice work, and realizing that you have to give yourself that space and that permission to realize that the work is larger than yourself. And so the time that you put into it, the education, the courses, the things you do, the work you do every day, those are all part of a larger change, a larger process that you're a part of and you're adding to, but it is not all you. And I think that is really liberating. But I'm so thrilled that we talk about self-care these days, because it's so essential to not be the hero that dies because of the weight of inequity and injustice in the world. So very, very, very important.
Yes, I mean, if we think about reducing the stress so that
Yes,
we have better health outcomes,
yes.
self-care is a big component because the data shows we're not winning in this spot at all.
Not at all.
Okay, I think we're going to turn to some audience questions. Thank you for that. I think that's an important piece that we didn't sort of talk about in the course, but I wanted to highlight in the webinar. So I think there's been a lot of questions, and first question. Can you outline some of the tangible ways to address racial inequities in healthcare? What tactical, practical steps can be taken now? Aside from taking the course, which outline those, maybe, let's see, anybody want to sort of take that question on?
Well, it's a very large question, and it comes back to my comment about the sources of disparities and the solutions of disparities being hyper-local. So, for example, for me as a clinical leader at a very large university, what we've been doing for many years is starting from the process before people engage our healthcare system, the whole process of registration, the process of having access to our healthcare, and actually structuring it to prevent the blind spots, to prevent the processes that will lead to inequity, and then building at every level from that moment of registration to the clinical care, to the training of the providers, to the measurement of outcomes, to the reporting, public reporting of those outcomes, on and on. Each step of the way may sound not sexy, but that's actually how change happens and how equities establish in an institutional setting. So that would be the beginning of a conversation about the answer to that question, that this is actually deep work that requires every level of the institution to be involved in.
Andrea?
I think I would add to that to treat patients as the subject matter experts of their lives, because there's so much information that can be gleaned just by having that rapport with a patient. And I think in designing solutions, like Lenny's saying, they're hyper local. I think that also means just having people within the community that are trusted to understand like where the core issues are, understand the root causes before we kind of go into like the treatment aspect of it. So I think bringing the community in and building that trust as well.
Esteban, did you have any comments?
Yeah, I agree with Lenny and Andrea. The only thing I will add is, if we all know that if you're trying to find disparities and you look for them, you will find them, right? And after you take the course, or while you're taking the course, and you're thinking about a particular project that you would like to embark on, I'll suggest that you get as specific as you can in your project. One of the things that I see from my students, for example, is that their goals are very broad, right? And we're all trying to solve everything in the world. And unfortunately, we may not have the bandwidth. So I will say at the individual project level, the more specific you get, the more tailored, the better the more successful you will be to measure and keep track of the progress.
Yeah, trying not to boil the ocean. I think the other piece, sort of bouncing back to what Lenny said, is, I do think data collection, that is a tangible step that you can take, is to assess the quality of your demographic data, because out of that comes a lot. And then I would say taking a journey and looking around in your community and seeing what are some of the historical milestones, events that happened that created the mistrust in the communities that you serve, between the communities and your organization. We don't like to do that. But we have to. I think that's core to understanding whether, our interventions or our strategies are going to work. They won't work if we don't acknowledge some of the historical events that have created a lot of the mistrust. We have to do that hard work.
I just want to quickly add to what you're saying, Aswita, what Andrea was saying, is that in this course and in this work, you have to realize that you're creating partnerships and allyships. You're not going into a community to save a community, and those approaches act as if the communities have no resilience, no empowerment, no resources, etc., when it's often not the case. So it's really that connection where the community and the systems and institutions work together that lead to long-lasting change. Because institutions are within communities, whether they want to think about that or not.
Yeah. This is a good question. I get this a lot when we do presentations for like an international audience, which is, do you feel like racial disparities and discrimination is a bigger problem in the United States and in healthcare in particular, or do you see similar issues internationally?
So I could start by saying that something to keep in mind is that the way that we conceptualize these concepts differ, in each country. Even the concept of race is very different. The way that we think about it here in the US versus is thought in Latin America, in Europe, etc. So that's something that I would should say, to keep in mind that a lot of these constructs, a lot of these concepts are particular to a particular culture, country, and are also moment in time.
I would also say, like, again, would echo that racism is seen differently. Racism's twin sister is colonialism, and there's colonialism all over the world that has affected populations. I think any community where you see there's a gradation in color, the people who are the darkest skinned are generally the ones that are facing the most discrimination, and you will find disparities there as well. So I think just because the conception is different, it doesn't mean that those disparities don't exist. It's just that I think in the US, we talk about it more, and it's like we have this history of slavery as well for hundreds of years. So I think it's just a difference of familiarity with the concept.
Yeah, and I would say, my home country is the Netherlands, and it's known as a very tolerant country. But even if we sort of look deeper under the hood, there's immigrant populations who are, not getting, the same treatment as somebody who is Dutch and born there. There's also religious oppression that probably mirrors the same thing. So there's and then there's tribal as well. We have tribal differences. So I would say it's really about what kind of social justice and oppression is do you need to look at, rather than thinking that, racial and ethnic disparities is just a US problem. That's sort of denying that your country may also have issues. Lenny?
Yeah, and I would add to what everyone is saying. And I think it's also a false dichotomy, because in reality, whether race is the discussion point, or socioeconomics is the point, or colonialism history is the point, all of them become deeply interrelated over time. So when you try to separate one out, the other is still embedded in it, And so I tend to tell people that whether the terms that are more primary in a context are meaningful to people, realizing that they're actually very similar and they're very correlated. So trying to separate those out often leads you to confusing conclusions that are usually not true.
Okay, I have one more question, and then we'll close it out. And Lenny, maybe I'll sort of punt this to you. So how can we integrate training on reducing disparities in formal medical training? How can medical students carry this work out? Medical students are the next generation, right? And so we have to be really mindful of being able to focus on them, because that is a wave of change as we see it. So any thoughts on that question?
Great question. I think about this a lot, given that I have trainees always working with me. And that is that the only way to do it is that it has to be actually embedded in the 4 years of a medical school curriculum from the very beginning. And not only the content, but the making space, formal space for reflection, for mentoring, for observation of what other senior doctors may be doing, handling these kinds of issues in the clinical context. So it actually has to be part of the culture. And that is done through the investment of money and time, protecting educators' times to actually be able to teach this material, as opposed to volunteerism, really embedding it in, this is an essential topic that every year we're going to discuss. throughout the coursework. But again, that takes time, money, and investment from the leadership of the institution. So very, very important if we're going to really change the needle. But it can't be a niche topic that's done in a small 10-hour seminar once or twice in 4 years. That is not going to work.
Yeah, multi-pronged effort, definitely. I want to thank the three of you for, joining me in this conversation. I knew that we would have a good conversation. I stacked the deck by asking highly intelligent friends and colleagues to join me on the panel who I really like. That just is very helpful and makes it, I knew all of you would show up and that you would bring your authentic self and your lived experience and your thoughtfulness to this webinar. So thank you again. And I'm now going to turn it over to Jim to close us out.
Great. Thank you, Aswita. And thank you, Lenny, Esteban, and Andrea. And thanks to all of you who've joined us today. We hope you'll continue the conversation in our new online course, Reducing Racial Disparities in Healthcare, which is launching on March 8th. Enrollment is now open. Applications are due by February 27th. And everyone who's registered for this webinar today will receive a discount code off the course in the chat, as well as an email that you'll be receiving soon. So thank you again for participating, and we appreciate your time today.